today's journal club is on the Realist trial. It is a study on mesenchymal stem cells in treatment of severe ARDS. This is basically a phase 1 trial. Mesenchymal stromal cells have been proposed as a possible therapy for ARDS with pleiotropic immunomodulatory, reparative, and antimicrobial effects. In the recent trials in COVID-19, we have seen the role of immunomodulatory agents like IL-6 inhibitors and dexamethasone. So based on that, they planned this study. It is in preclinical models of ARDS, these mesenchymal stromal cells have shown to improve physiological outcomes like oxygenation, lung compliance, and also have improved survival. In human ex vivo lung perfusion models, the stromal cells effectively restored the alveolar fluid clearance, a measure for integrity of the alveolar epithelial endothelial barrier. Now, what are the mechanisms by which it produces its effect? The first is the antibacterial effect. The antibacterial effect has been seen in various pre-human studies. They produce by secretion of certain agents like beta defensin 2 and other antibacterial secretions. So these are basically paracrine secretions which inhibit the growth of and the bacteria. The next is mitochondrial transfer of from the mesenchymal stem cells into the damaged cells. This mitochondrial transfer helps in recovery of these cells. Now, this has been also seen in various cells where the transfer of the mitochondria from these cell into the damaged alveoli helps in removal of the bacteria and decrease in inflammation and also repair in the damaged alveolus. The last is the extracellular vesicles are formed, which helps in better clearance, improving the macrophage performance and removal of the inflammatory agents. So in this, they used a cellular product which consisted of stem cells which they collected from the umbilical cord. It was a CD382 line of cells. Now, the advantage of using the umbilical cord was that over bone marrow cells is that it is present in abundant amount from the source and it is readily available without any risk to the donor, and which makes it less expensive and more safe to the donors in case of retrieval of these stem cells. Now, the UC derived, that is the umbilical cord derived mesenchymal stromal cells have demonstrated comparable efficacy to bone marrow derived cells in clinically relevant ARDS models. Now, this was a phase 1 trial in which they tested the safety of single intravenous infusion of these stromal cells in mechanically ventilated patients with moderate to severe ARDS defined by the Berlin criteria. The maximum tolerated dose over the range from 10 to 400 into 10 to the power 6 cells was determined. The study design, it was a phase 1 open level dose escalation pilot study in which cohorts of subjects with moderate to severe ARDS will receive increasing doses of single infusion of the stromal cells in a 3+3 design. I will come to what this 3+3 design is. Now, the PICO terms, in terms of PICO, this study means the population is basically young patients or adult with moderate to severe ARDS. The intervention here is 400 into 10 to the power 6 cell dose of mesenchymal stromal cells. The comparator is placebo and outcome is safety and physiological indices of efficacy. Population, they included patients with moderate to severe ARDS defined by the Berlin's criteria. The onset should be within 1 week, within 24 hours of time period. And I'm not sure how they have calculated this PF ratio. It's slightly different from what we use. Now, in this, the hypoxic respiratory failure was less than 27 and PEEP of more than 5, similar to the Berlin's definition criteria. And the exclusion criteria was patients who are on ventilator for more than 48 hours, age less than 16 years, patients who are known pregnant, participated in the trial within 30 days, major trauma, active malignancy, and other various contraindications. So this is how they did the study. They daily screened the ICU for mechanically ventilated patients. They then saw if the patient had the criteria for moderate to severe ARDS. Now, patients with ARDS were assessed for eligibility. Once the eligibility was defined, consent was taken and infusion was done. Totally, they had planned up to 18 patients to take in the study. Data collection was done for safety, pulmonary and non-pulmonary organ function, bronchial valve lavage, blood and urine samples were taken. So this is the 3+3 design. Initially, they recruited 3 patients in an intervention group, that is 100. If there was no severe adverse effect, then the dose was escalated. If 2 or more than 2 patients had a severe adverse effect, the study was to be terminated at that point. Similarly, in the next dose, 3 patients were to be taken. At any point, if 2 or more than 2 patients saw any kind of severe adverse effect, then the study is to be terminated. So the plasma containing the stromal cell was thawed and diluted in plasma light 148 to a total volume of 200 ml. Lab studies demonstrated more than 70% viable cells in the thawed and diluted preparation in accordance to the study SOP. This was at 6 hours. Now, patients were administered an intravenous dose of chlorpheniramine 10 milligram before admission of the plasma to reduce any histamine mediated effects of the stromal cells in the cell cryopreservative. And this was infused over a period of 30 to 90 minutes, and the infusion was to be completed within 6 hours because this viability was tested maximum at 6 hours. Beyond that, it was not. What were the adverse effects they were looking? They were looking for increase in the dose of NORAD or adrenaline. This was the escalation in dose of NORAD which they were looking for. Or there was a initiation of NORAD or vasopressin or adrenaline. New ventricular tachycardia, new cardiac arrhythmia, worsening of the hypoxemia, clinical scenario consistent with transfusion incompatibility or transfusion related infection, that is urticaria, new bronchospasm, and any of these criteria which if occurred within 24 hours, that is death, cardiac arrest, or temperature recorded more than 38 degrees centigrade, or if it was more than 30, then a degree increased by more than 1 degree centigrade. So this was how they recruited. Total 127 patients were assessed for eligibility, 118 were excluded. Out of this, they allocated 3 in each group, that is 9 patients were included, 3 in each group. They followed them up and all the 3 patients could be followed up till the end and they were included in the analysis. So total 9 patients, 3 in the 100, 3 in 200 and 3 in 400 group. The gender was mostly male, female was 1 patient each, age was around 50. Etiology of ARDS was varying from sepsis to pneumonia to aspiration pneumonia, even trauma cases were included. Apache 2 was around 19, lung injury score was around 2.5. The worst PF ratio, this is slightly different formula from what we are using, it was 18.5 in this case. Total SOFA was 13, oxygen index was 84.6. PEEP was around 10, plateau pressures of 25, driving pressure of around 15. But if you can see here, the patients who were in the 200 group had a quite higher plateau pressure, that is around 18. And even the while the patients in the 100 group had a plateau pressure of around 9. Tidal volume was around 6 to 7. Now this is the individual data of each patient. The first 3 patients received 100. All of these patients survived. They had Apache of around 21 patient had Apache of 10. So in the 100 group, the diagnosis was sepsis, trauma, and pneumonia. In the second group, they were slightly worse of patients with worsening Apache 2 as well as the PF ratios. They had a diagnosis of 2 cases had aspiration and 1 had pneumonia. While in 400 group, there was 2 pneumonia and 1 aspiration. All the patients died in the 200 group, all the 3 patients, and 1 patient died in the 400 group, while all the patients survived in the 100 group. This was the main thing which they were looking for, that is the adverse effects. Adverse effects were mostly mild, and that is pyrexia, non-sustained VT, and deranged LFT. Serious adverse effects, that is perforated duodenal ulcer, myocarditis, colonic perforation, bradycardia, was all these 4 were seen in some patients, but this was mostly not related to the treatment that was being given. So most of the complication maximum that was seen that was possibly related to the infusion of the study drug was mild adverse effects. No serious adverse effects was noted with any of the doses that was given, and most of them occurred within the first day of infusion. Now these are the inflammatory markers. The dark line indicates dose 1, that is 100. Then the lighter shades go from 200 and 400. So there was gradual reduction in all the inflammatory markers. Not much difference in terms of dosing. Similar effect is seen over here. Though in some parameters, you can see that the 400 dose has shown lower values for the inflammatory markers. Now, this is the lung parameters, that is oxygenation index, driving pressure, PF ratio, SOFA, and respiratory compliance. Again, most of them are showing improvement, and with the 400 dose, there is even better improvement in some cases. Coming to the conclusion, since the most important thing they were looking for, since it was a phase 1 trial, they were mainly looking for serious adverse effects and to find a dose for the second phase 2 trial. So based on that, they concluded that a single intravenous dose of the stromal cell up to 400 can be given, and it is safe and feasible in critically ill patients because most of the complications were mild. Based on the absence of dose-limiting toxicity, the safety concerns in this, there are no safety concerns in the phase 1 trial, and a dose of 400 has been approved for phase 2 intervention. That is this particular study, which is currently going on. And in this, they will look more into the outcomes and to see whether this, when compared to a placebo, will produce any improvement in the ARDS or not. Thank you.